Our topic for discussion for today is on third molar impaction. So what is an impacted tooth? A tooth which has ceased to erupt into the oral cavity because of any kind of a physical obstruction, which can be the presence of another tooth or soft tissue or even hard tissue. So this is what is an impacted tooth. Now, what does the Latin word impactus mean? It means an organ or a structure which, because of an abnormal mechanical condition, has been prevented from assuming its normal position. There are various definitions that was put forward by Archer and Peterson. So according to Archer, a tooth which is completely or partially unerupted and is positioned against another tooth or bone or soft tissue so that its further eruption is unlikely has been defined as an impacted tooth. According to Peterson, a tooth is considered impacted when it has failed to erupt fully into the oral cavity within its expected developmental time period and can no longer reasonably be expected to do so. That is, a tooth which has lost its eruption potential. So tooth eruption is where the tooth moves from its site of development within the alveolar bone to its functional position in the oral cavity. So that takes place in various stages. You have the pre-eruptive stage, you have the intraosseous stage, the mucosal stage, the pre-occlusal stage, the occlusal stage, and the stage of maturation. Now here the important terminologies that you have to keep in mind is how is an impacted tooth different from an unerupted tooth? How is that different from a malposed tooth? So an impacted tooth is that which has failed to erupt fully or partially into the oral cavity because of any kind of a physical obstruction, as I told you earlier. And this tooth has also lost its eruption potential. Whereas an unerupted tooth is that which has not lost its eruption potential and is likely to erupt into the oral cavity in the future. The malposed tooth is one which has erupted in an abnormal position in the dental arch. Coming to the most commonly impacted teeth, the most commonly impacted teeth is the mandibular third molars, which is followed by the maxillary third molars. Still less commonly impacted is the maxillary canine, followed by the mandibular premolars, the maxillary premolars, the mandibular canine, the maxillary central incisors, and least commonly impacted is the maxillary lateral incisors. So the most commonly impacted is the mandibular third molars. Now coming to the theories of impaction, why does an impaction take place? So there was different theories that was put forward, and this is put forward by Durbeck. Now, namely, these theories are orthodontic theory, you have the phylogenetic theory, the pathological theory, the Mendelian theory, and the endocrinal theory. Now, what does the orthodontic theory state? It states that the growth of the mandible, it usually takes place in the forward and the downward direction. And if there's going to be any obstruction in this growth, that is going to cause an impacted tooth because of the small jaw size. So this can be even dense bone, which can cause a difficulty in the forward and downward growth of the mandible. So as a result of which you have a smaller jaw size. Now coming to the phylogenetic theory, it states that the nature usually tries to eliminate those organs which are in disuse. So because primitive man used to use the jaw much more than modern man. Modern man has refined food, and the entire food habits or the lifestyle has changed, because of which the use of the jaw has decreased over time. So because of that, you have smaller jaw size, as a result of which you can have impacted teeth. Now coming to the pathological theory states that if there's going to be any kind of chronic infection, that can cause osseous condensation of the bone, as a result of which can hinder the growth of the mandible. So that is what the pathological theory states. Now coming to the Mendelian theory states that hereditary is a cause for impacted teeth. That means you get the jaw size from one parent, that is transmitted from one parent, and the tooth size is from the other parent. So usually there's a discrepancy here. That is, you have small jaw size and larger teeth maybe. So in that case, you can have impacted teeth, and because of the smaller jaw size. Coming to the endocrinal theory, the endocrinal theory states that it is the increase or decrease in the growth hormones which decides the size of the jaws. That means if you have decreased growth hormones, then there's going to be smaller jaw size, as a result of which you can have impacted teeth. Coming to causes of impaction, These causes can be either local causes or systemic causes. Local causes are obstruction for eruption. That is usually soft tissue or hard tissue or even another tooth. Then you have lack of space because of the smaller jaw size or maybe larger tooth size, ankylosis of the tooth, non-absorbing alveolar bone, over-retained deciduous tooth, ectopic position of the tooth bud, dilacerated roots, soft tissue or bony lesions, and you have habits like thumb sucking, which can cause impaction. Then you have systemic causes. These causes can be either prenatal or postnatal. Prenatal is usually hereditary. And then you have postnatal causes like congenital syphilis, rickets, malnutrition, endocrinal disorders, which includes that of the thyroid, the parathyroid glands. Then you have direct causes like that is associated with a syndrome like the Down syndrome or the cleidocranial dysostosis, or even cleft lip and palate. Now coming to indications for the disimpaction surgery and contraindications for the disimpaction surgery. So why would you do a disimpaction surgery? Because of the most common cause is usually a recurrent pericoronitis. That is the entire gingiva in the area that is covering the tooth is going to get infected multiple number of times. And for that reason, you would want to remove this tooth out. Then coming to deep periodontal pockets prior to orthodontic treatment, because you don't want the eruptive forces to cause a malalignment or relapse of the orthodontically corrected teeth. Then prevention of root resorption of the second molar, retained deciduous teeth, any kind of prosthetic concerns where you want to place a denture and this is coming in the way of the denture placement, tooth and line of fracture. Tooth and line of fracture, when you talk about this, if the tooth itself is fractured, you might recommend its removal. If it is an open fracture and the periodontal ligament space is involved, in that case, there is all chances that this tooth can be infected. So unless and until it's going to help in your reduction and stabilization of the fractured angle, in that case, you can leave it in place till you have fixed the fracture. If it is a closed fracture, you might want to wait and see. If the tooth is going to help in the reduction of the fractured segments or it holds the fractured segments in place, then you would want to leave it there. Then coming to management of cysts and tumors, if this tooth itself is involved with any kind of cyst and tumors, you would want it removed, and prophylactic removal, of course. Now coming to the contraindications. Contraindications can be extremes of age. That is, if your patient is too young or the patient is too old, compromised medical status of the patient, if there's an excessive risk of damage to the adjacent structures, if there's a nerve or canal passing right under the tooth, when the future status of the second molar is questionable, because the second molar can be vastly destructed and that might require removal. So in that case, you would want to leave the third molar behind so that this can serve as function later. Uncontrolled active pericoronal infection, that is, in presence of an infection, you don't want to remove the tooth because this can cause a spread of infection to the spaces. Then coming to fracture of the atrophic mandible. That is, if there's a risk of fracture of the atrophic mandible, then you would want to leave the tooth behind. Coming to the classification of third molar impaction, you have various classifications. So the first one is based on angulation. So you look at the angulation of the third molar in relation to the second molar. So you have it classified as mesioangular, distoangular, vertical, horizontal, buccoangular, lingoangular, and inverted. So this classification was put forward by Winter. So this is Winter's classification based on angulation. You have another classification which is put forward by Pell and Gregory, which is based on the depth. So based on the depth, this has been classified as position A, B, and C. Position A is where the highest position of the tooth is at the level or above the occlusal line. Level B is where the highest position of the tooth is below the occlusal plane but above the cervical level of the second molar. And position C is where the highest position of the tooth is below the cervical level. So from this itself, we can understand that level C is considerably more difficult for removal when compared to level A, where the tooth is at the occlusal level. Now, apart from this, you have another classification again put forward by Pell and Gregory, and that is based on the space availability between the distal surface of the second molar and the ramus of the mandible. So the first class, that is you have class 1, 2, and 3. Class 1 is where you have sufficient space for eruption of the third molar. That is, the third molar can erupt easily into the oral cavity, and that is given, that is put forward as class 1. Then you have class 2, where the space available between the distal surface of the second molar and the ramus of the mandible is comparatively lesser when compared to the mesiodistal width of the crown of the third molar. That means there is less space available for eruption. So that is at the class 2. Then you have class 3, where the entire tooth is going to be embedded into the ramus. That is, there is no space for eruption of the tooth. So there is absolute lack of space. Now coming to classification of the maxillary third molar impaction. And this was put forward by Archer, and it is similar to the Winter's classification, which is based on angulation. So the classification goes as mesioangular, distoangular, vertical, horizontal, buccoversion, lingoversion, and inverted. So similar classification, which is put forward by Pell and Gregory, based on the occlusal plane. Class A, where you have the tooth is at the occlusal plane. Class B, where you have it below the occlusal plane but above the cervical margin of the second molar. And class C, where it is below the level of the cervical margin. Now coming to classification of the maxillary third molar, which is based on the relationship to the maxillary sinus. So one, you have no sinus approximation, and the other you have sinus approximation. No sinus approximation is where there is 2 millimeter or more bone that is available between the sinus floor and the impacted maxillary tooth. And sinus approximation is where there is either no bone or a thin partition between the maxillary third molar and the floor of the sinus. Now coming to classification of the maxillary canine. Now the maxillary canine has been classified as class 1, 2, 3, 4, and 5. Now what is class 1? Class 1 is where the impacted cuspid is located in the palate. So this can be either horizontal, semi-vertical, or vertical. And class 2 is where this is located in the labial or the buccal surface of the maxilla. So that also can be either horizontal, vertical, or semi-vertical. Class 1 is where it is located in the palate. Class 2 is where it is located in the labial surface. Now you have class 3, where the impacted cuspid is located in the palatine and the maxillary bone. That means crown is partially either in the palate and the root passes through the labial surface. So you have one part of the tooth in the palatine bone and one part of the tooth in the maxillary bone. Then you have class 4, where the impacted cuspid is usually located vertically in the alveolar process between the incisors and the first bicuspid. And you have class 5, where the impacted cuspid is located in the edentulous maxilla. Now coming to the difficulty indices for removal of the mandibular third molars, you have classification put forward by Pedersen. So what is the difficulty index for? It is used for analyzing how difficult is your impaction going to be and whether you will be able to carry out this procedure under a local anesthesia or would you have to opt for a general anesthesia procedure. So the Pedersen scale has classified it based on the spatial relationship, all the classifications that we earlier spoke about. That is based on the spatial relationship, based on the depth and the ramus relationship for space availability between the distal surface of the second molar and the ramus of the mandible. So based on spatial relationship or based on angulation, it has been classified as mesioangular, horizontal, vertical, and distoangular. Now, based on the simplicity for removal of this tooth, it has been given various scores. So mesioangular is given a score of 1 because it is considered more easier for removal, whereas distoangular is considered difficult, and as a result of which score is given of 4. You have based on depth, where level A, of course, position A is at the occlusal plane. So a score of 1 is given, and you have level C, where it is below the cervical margin of the second molar, as a result of which a score of 3 is given. Now, based on the relationship or space availability, you have class 1, 2, and 3. Class 1 is where you have enough space for eruption of the tooth, and that is given a score of 1. And class 3 is where the entire tooth is embedded into the ramus, as a result of which you have a score of 3, which is greater. So a total score of 10 is given, and based on this, the difficulty index is calculated. So if it is very difficult, you have a score of 7 to 10. So anywhere between 7 to 10 is regarded as very difficult. Moderately difficult is 5 to 7, and minimally difficult is 3 to 4. So if you have a score of 7 to 10, that is, if you have the greatest score, you might want to do the procedure under general anesthesia. Coming to the parent scale, the parent scale is based on the technique used. That is, if extraction is done with the forceps alone, it is given as a score of easy. Difficulty index is easy. And extraction requiring an ostectomy, it is easy too. Extraction requiring osteotomy with a coronal section, that is given as difficult 3. And complex extraction, which requires a root resection, is given as an index of difficulty 4. Now coming to a very important line of measure of the difficulty index, you have the WAR lines, WAR lines. So these are color-coded lines, and of course, this is interpreted in a IOPA or even a OPG. And you have 3 lines here, WAR. So W stands for white line, A stands for the amber line, and R stands for the red line. The white line, it corresponds to the occlusal plane of the molar teeth, and it indicates the difference in the occlusal level of the second molar and the third molar. That is, where does your third molar stand in relationship to your second molar? That is what the white line denotes. Then you have the amber line. The amber line, it represents the bone level. That is the amount of alveolar bone covering the impacted tooth. That is what it denotes. Now the red line is an imaginary line which is drawn as a perpendicular from the amber line to the point where you will be applying an elevator. So that represents the depth of the tooth in the bone and how much of bone you might need to remove before you remove this tooth out. So if the red line is more than 5 millimeters, then the extraction is considered as difficult. So with increase in 1 millimeter of the with every increase in 1 millimeter above 5 millimeters, then the difficulty index increases by 3 times. Then you have the WARF assessment, which is also difficulty index. So the WARF assessment, WHARFE. The criteria are: W stands for the Winter's classification, H stands for the height of the mandible, A is for angulation of the third molar, R is for root shape, F is for follicle size, and P is for path of exit. So the Winter's classification is as horizontal, distoangular, mesoangular, and vertical. So vertical is considered easy, so given a score of 0, whereas horizontal is given a score of 2. Height of the mandible 1 to 30 millimeters is given a score of 0, whereas the greater the height of the mandible, that is above 35 to 39 millimeters, it is given a greater score of 2. Angulation of the third molar, if it is the angulation is 1 to 59 degrees, a score of 0 is given, whereas if it is greater than 90 degrees, a score of 4 is given. Based on root shape, you have complex, favorable, and unfavorable. So if it is complex, then it is given a score of 1, and if it is unfavorable, then it is given a score of 3. Follicle size, if the follicle is normal, a score of 0 is given. Enlarged, a score of 2 is given. Path of exit, if there's space available, then a score of 0 is given. If both the cusps are covered, it is given a score of 3. So the greatest measure here is 16, and based on that, you can identify how difficult your impaction is going to be. Now, the radiographs that is ideal for this would be either an IOPA or an OPG, occlusal, lateral ceph, PAView, CBCT, all these can be taken. Now, why do you want to take a radiograph? This is to understand the root pattern, of course, to understand what classification of impaction does your tooth fall under, so that you can analyze how difficult it is going to be. Apart from that, you also want to know the proximity of this tooth to the inferior alveolar nerve canal. So based on that, the relationship to the inferior alveolar nerve canal, you can see changes in the root. If you look at an X-ray, you can see changes in the root, or you can see changes in the canal. And that way you can identify if your tooth is going to be anyway close to the canal. So if you see darkening of the root, if you see deflection of the root, you see narrowing of the root, you see dark bifid apex, all these are changes that you can see to the root in case it is in proximity to the inferior alveolar nerve canal. What changes can you see in the canal itself? If there is a proximity of the tooth, you can see interruption of the white line of the canal. You can see diversion of the canal, and you can see narrowing of the canal. So this is what you have to look for in order to identify how close is your tooth to the inferior alveolar nerve canal. So what is the risk of non-intervention? What is the risk of intervention? The risk of non-intervention is that there can be crowding of the dentition, there can be a resorption of the adjacent tooth, and the periodontal status of the adjacent tooth can be weakened, development of pathological cysts or tumors, or you can also have space infections. Now, what is the risk of intervention? The risk of intervention can be either minor, transient, minor permanent, or even major. Minor transient is usually sensory nerve alterations. You can have alveolitis, trismus, infection, hemorrhage, dentoalveolar fractures, displaced root. Apart from this, you have minor permanent, like you have periodontal injury, adjacent tooth injury, or even TMJ injury for that matter. You have major, still more complicating can be where you have altered sensation, you have vital organ infection, fracture of the mandible itself, or even maxillary tuberosity fracture. Coming to the surgical steps in the removal of impacted teeth. The general considerations are for adequate exposure, access to the tooth, sectioning of the tooth if required, elevation of the tooth, debridement and irrigation, repositioning of the flaps enclosure, and post-operative follow-up. So principles of flap design is that the base of the flap must always be broader so that there is enough of circulation or enough circulation towards the flap. Then you have adequate size for visualization of the tooth. Full thickness mucoperiosteal flap must be reflected. The incision should always be on intact bone. You should avoid injury to any local vital structures like the nerve or the canal. Incision should always be placed away from the lingual aspect. Releasing incision should always be placed away from the facial aspect or the interdental papilla. So these are the principles of flap design. So what are the various flaps that are used here? You can have envelope flaps, you can have triangular flaps, you can have modified triangular flaps, cismet flaps, binet flaps. So all these are different flaps that can be used in the surgery. You have the Watts incision, which usually starts, which is a 3-limb flap, usually starts from the distal end of the second molar. You have a releasing incision. You have a clavicular incision, and then you have a distal incision. So you have modified Watts incision, where you have an incision which is from the distal surface of the first molar. Coming to reflection of the flap, it begins at the papilla. The mold number 9 mucoperiosteal elevator is usually used for this purpose. You usually pry the papilla away from the underlying bone, and the reflection should be as atraumatic as possible to prevent any soft tissue damage. Bone removal can either be done using a burr or a chisel and mallet. Burr technique is considered to be more easier, whereas a chisel and mallet is more difficult. The burr technique, you have more controlled forces that you can give, whereas a chisel and mallet, you need patient acceptance for its tolerance. Whereas when it comes to healing, usually the bone burr technique, there is delayed bone healing, whereas using a chisel and mallet, the healing is usually good, and post-operative edema and dry socket chances are very less when you compare it with the burr technique while using a chisel and mallet technique. Also, the chances for a post-operative infection is much less in a chisel and mallet technique when compared to the burr technique. The only problem here is patient acceptance. Patient is usually well tolerates the burr technique. The burr technique is also called as a Murray-Gilbey collar technique. So in this technique, you use a burr of diameter 1.5 millimeters. You can either use a large rosehead burr or a straight fissure burr. And usually with the rotation of this burr, you need copious amount of normal saline irrigation. So a margin of bone is removed to create a point of application of the elevator. So irrigation can be done either using saline, sterile water, or even Ringer's lactate. In Chisholm-Mallet technique, you have to support the mandible properly because you use a free swinging wrist motion for ostectomy. And yeah, as said earlier, the post-operative complications like dry socket infection is much less with the Chisholm-Mallet technique when compared to the Burr technique. Next, coming to the lingual split technique, which is put forward by Sir Kelsey Fry. This is for faster removal of tooth, and there is this lesser risk of damage to the inferior alveolar nerve. There's also lesser risk of damage to the second molar. Here, what you do is you place a vertical stop cut below the second molar, and from the lower end of this, you place a horizontal cut. You remove part of the buccal plate. You fracture the distal lingual portion of the bone, and you remove that bony edge, and you elevate the tooth out. So once that is done, you reposition the flap and suture. So this is what is a lingual split technique. It is more ideal if your tooth is placed lingually. There is lesser risk of damage to the lingual nerve while doing this technique. Then you have the definition technique. So in this, the lateral definition technique, it involves placing small burr holes. This was put forward by Boulder Henry for the removal of any kind of unerupted third molar which has been partially formed. That is between 9 to 16 years of age, where you just have a crypt. In this, what you do is place a modified S-shaped incision from the retromolar fossa area to the external oblique ridge area. And after reflecting a mucoperiosteal flap, you trephine the buccal cortical plate over the third molar region, and you join these trephined holes with a chisel or an osteotome and fracture that portion of the buccal plate out. So once that is fractured, you'll be able to remove the crypt of the tooth easily. So after this, the flap is repositioned and sutured. So this can only be performed where you have unerupted third molars which are formed partially. So that is between the ideal age group of 9 to 16 years of age. Wound closure. Here, the most important suture is the one that you're going to place right behind the second molar, so as to prevent any kind of damage to the second molar. You don't want the second molar to become periodontally weak after removal of the third molar. You can also place drains. Small rubber drains can be placed 24 to 72 hours. First, it should be removed after 24 to 72 hours. So that helps in drainage. Now coming to the complications. Complications can be intraoperative or postoperative. Now during the incision, what can go wrong is here there can be injury to the facial nerve or the vessels. During bone removal, you can have damage to the second molar, slipping of your burr into the soft tissues, fracture of the mandible itself. During elevation, there can be luxation of the neighboring tooth, soft tissue injury, fracture of the mandible again, forcing the tooth into the spaces like the submandibular space or even the inferior alveolar nerve canal, or even breakage of instruments can happen. TMJ dislocation can happen. During debridement, what can go wrong? Here, there can be injury to the inferior alveolar neurovascular bundle. So post-operatively, there can be pain, swelling, hematoma, of course, bleeding, trismus, infection, dry socket, TMJ pain, paresthesia, and sensitivity. This is what you're looking for post-operatively. So if your patient is managed properly with adequate medication, keeping in mind to be very careful while you do the surgery, from the time you place an incision to the time you debride, you can avoid a lot of intraoperative complications. So we come to the end of today's class with that. So thank you. We'll catch up for the next class later. Thank you.